Afternoon, Good afternoon, everyone. I'll try that now. Good afternoon, everyone. Now it's working better, right? Okay. Having some technical issues today. Making sure that I'm connected with my video and my microphone with the right devices. And also gonna share my screen, I hope. We'll see how this goes as well. I am assuming that people can see this.
Yes, Director, we see it.
Wonderful. So first of all, not very good news to report. As you can see, November was not a good month at all. A total of 34 people diagnosed with COVID. That's 27 more since the last time we met. So that we are now up to 297 people who have tested positive for COVID-19 amongst the people we support. I changed this a little from before so that people can sort of see the representation of the people with COVID versus their overall representation by placement type supported by DDA, so that you can see, for example, on the left-hand side, during the course of the year, 299 people were in intermediate care facilities. Out of those, 102 have tested positive for coronavirus. So, you know, by proportion, that is much higher. So we can see that the folks who have been most at risk for contracting coronavirus have been the people who live in intermediate care facilities. So that to date, there have been 102. In host homes, we have 91 people who are in host homes and 5 who have tested positive for coronavirus to date. In natural homes, there are 931 people who live with their families in natural homes or live in their natural home. And of those, 29 have tested positive. In residential habilitation, we have 110 people and 32. So while that number 32 may not sound that big, you can see it still is a larger representation. It's a higher percentage than many of the other placement types. And then in supported living, we have about the same number as we have in natural homes. There's about 932 people who are in supported living, and out of those, 127 have tested positive for coronavirus. And as you can see here, sort of the COVID rate by placement type, overall of the people that we support, we've seen 12.36% of those people have tested positive for coronavirus. And in terms of placement type, it is not surprising at all that in our congregate settings, we're seeing a much higher rate of coronavirus, 34% in ICFs and 29% in ResHab. The percentage in natural homes is only 3.11%, which is very positive. And I will say, I think I've mentioned before, since July, we do have access to the Medicaid data, and we have access to the CRISP system, which gives us medical information. So while prior to that date, there may have been folks who tested positive where we didn't get the report, we're now getting, we hope, a pretty thorough report of people who are in natural homes testing positive. As you can see, the outcomes for people. So, and I'll talk about this in a couple minutes, the outcome in terms of the most serious outcome. To date, we have had 37 people who have tested positive for coronavirus have died. Now, some of those have died subsequent, And in 2 instances, we have had an OCME determination that it was not, in fact, that coronavirus was not the cause of death. We do still have 7 where we have not gotten a final determination from OCME about the cause of death. And so in terms of the mortality rate for people who've contracted coronavirus, I have 2 separate numbers for each placement type and overall. So overall, the percentage of people who contracted coronavirus who subsequently died is 12.45%, and the percentage where we have a determination or a presumption from OCME that it was coronavirus is 9.42%. In supported living, overall, people with coronavirus who've died, it's been 8.6% of those who have tested positive, and that have a confirmed or presumed cause of death being coronavirus, 6.29%. And the reason I say confirmed or presumed is when someone is in the hospital diagnosed with coronavirus, has pneumonia, and dies, at that time, they are presumed to have died from coronavirus. We will get a subsequent confirmation. As I said, we have a number of people where they had coronavirus and then months later they died. So we're waiting for the determination from OCME about that cause of death. So in ResHab, there's no distinction between the two. We've had 6.25% of the people who contracted coronavirus have died from it. In natural homes, it's been much higher. 17.24% of the people who contracted coronavirus have died, and we have a confirmation that 13.79% of those were from coronavirus. And in intermediate care facilities as well, it's a high percentage, which we might expect to see, more serious outcomes, because we do have some people who are more medically compromised in intermediate care facilities. They have more underlying health conditions. So it's been 16.66% who've had coronavirus who subsequently died, and 13.72% where we do have a confirmed cause of death as COVID-19 or a presumed cause of death as COVID-19. So as you can see, diagnosis by month and by placement type, there was a bump up in November. Most significantly, this bump up has been in ICFs and then in supported living. And as well as, so in residential habilitation placements, we had not had a case of coronavirus since July, and in November we had 5. I will say all 5 occurred in one placement. And this is one thing that we have seen in terms of our numbers in November, is that what we see is in congregate settings, we're seeing a number of people test positive. And I'm going to talk about that a little more in just a bit when I talk about the staff. But, one thing that occurred to me this week, as we've seen this big bump up in numbers, is that in April, when we had our most significant numbers, because of the availability of testing, only people with symptoms were tested. We now, with DC Health, there is a protocol so that if a person in a home is diagnosed with COVID-19, then everyone else in the home is tested. Everyone who lives in the home is tested every 3 days. So we are identifying all people who have contracted it. In some instances, it has been people who are asymptomatic, and we're monitoring them throughout. It's very important. Overall, we're seeing some better outcomes. And so it's very important that we stay on top of it and catch it early to make sure that people are getting whatever treatment they may need. So people who required inpatient treatment for COVID, we did see a bump up of people needing inpatient treatment. Since the beginning, we've had 121 people who have required inpatient treatment. In November and to date in December, we've had 10 people who required inpatient treatment. We currently have 6 people who are still in the hospital. And we have had 166 people who have not required inpatient treatment for COVID. So as I said before, people who have been diagnosed with COVID who have died, in November, there were 3 deaths. Only one of those is so far presumed or confirmed as a COVID-related death. Overall, though, there have been 37, and as I said, there have been 2 where there was a determination by OCME that it was not in fact COVID. And if we look at those where there's been a confirmation, it does bear out where I say the outcomes mostly have been better. We had 1 death in November that we know was COVID related, and 1 in July. Prior to that, of the 28 deaths that we either know or presume are COVID related, 26 of those occurred in April and May. So amongst our provider staff, to date, there have been 443 staff who have tested positive for coronavirus. 34 of them who work at more than one agency. We have really got to talk about, we need to continue to reinforce for all of us, but especially for the staff who are in these placements, who work with, in the case of people working in ICFs, or even, some of our folks in supported living or in their natural home, are people with serious underlying conditions. It is essential that all of us are paying attention to the mitigation measures that we're all supposed to be taking all day, every day. Outside of our home, we need to have a mask on. We need to continue to social distance. We need to continue washing our hands regularly. All of these measures are essential, because what we've seen is in some home, and it's really a concern, we see some homes where 8 staff have all tested positive in the home. So you start to wonder, what does the mitigation look like in that home? Are they exercising the kinds of caution regarding the use of face covering, regarding, surgical or procedure masks, a face shield, maintaining social distance, all of those things that are so essential. I didn't say at the beginning, but let me just say that Daryl Hawkins, I'm like blanking on her last name, who is with us every week from DC Health, is not with us this week, but DC Health is on the line, and we have a number of folks from DC Health who will be available to answer questions should there be health-related questions. Nelson Vanucci, Andrea Coker, and Dr. Anitra Denson are all with us, and they will answer questions that come up. So, just so that people are aware, I began to do some drop-in visits this week with our provider agencies, both in day programs as well as ICFs, ResHabs, and supported living, so that we could check in on, we've been doing virtual monitoring since the beginning. Our quality resource specialists do it. Our service coordinators are there. I know Quality Trust continues to do their monitoring. But I will say, when you go there in person, and I know that our provider agencies are doing their own monitoring, as well as, in, I hope, all instances, in-person monitoring. What it reinforced for me by going out to the homes is how essential it is that there continue to be ongoing, regular, I don't want to call it training, discussions, because training is that thing that you turn on And, you know, it's like, is there a test at the end? I'll take the test. There need to be ongoing discussions, ongoing reminders about the importance of all of these steps that we need to be taking in terms of masking, maintaining distance. And for staff, that means from each other. I know this was one of the things in one of the homes I went to, which the person I was with and I joked about, how we kept moving to make sure that we were maintaining a distance from the staff. And I know that I've seen some questions raised about, you know, whether the people that live there are maintaining a distance when they're eating their meals or when they're sitting and watching television. But staff who are walking around and engaged in activities and, you know, working with people, they also, and in a house, it is so much more difficult, need to be mindful of how close they are to people. We need to be wearing the masks in ICFs and ResHabs, wearing a face shield, and maintaining a distance. And I appreciate that there are certain tasks that a staff needs to perform where they need to be right up next to the person they're helping with that task. And certainly that makes sense, and that reinforces the need to be carefully complying with all PPE requirements. We will be continuing to do these drop-in visits and continuing to provide feedback to the various agencies about what we're seeing and, you know, the areas where we feel that they need to strengthen their training and monitoring. So there's a, at some point today, can you or one of your staff talk about the new POC portion of MCIS? I am not familiar with a POC portion of MCIS. And so if there is anyone who understands what that question refers to, if they could please jump in and answer. Perhaps we need some more clarity because no one is answering so far. Someone could also answer if there's a staff person who's available, but not one of the presenters, if they could just type in and make sure that when you are typing in the chat box, that you are typing in, that you scroll down and type in to everyone. And that's something, if people have questions, please scroll down to where it says everyone and type in your question. There is a, in the drop down, one of the first things you come across is all attendees, and everyone but those of us who are not muted and can answer your question will see that. So someone from service coordination, who I hope is here, Winslow is out today, so he's not able to respond to this. There's a new plan of care section. It's the new way that they access prior authorizations. And if there's someone from service coordination or waiver who can answer this, because I wasn't aware of any change regarding this.
Director Reese, I've added Robin and Shasta to our panelist chat, so hopefully one of them can provide some insight.
Hi, this is Shasta. Hello, everyone. I am actually reviewing the communication that was sent out by Pam Harmon. She sent an email out to all of the providers with the screenshot on how to actually view the new plan of care that's in MCIS. That email was sent to the provider community on October 27th. But so I'm trying to review it. I don't know if anybody from waiver is on the line. Can I share my screen? Hello?
I'm sorry, you can share your screen, Shasta? Give me
Yes,
one.
I'm going to pull up the email communication that came from Pam Harmon that went out to the provider communities about how to view the POC, the new process for viewing the POC.
You should have the right to share now.
Okay, let me see. I hope this is the right one. Okay. All right. So it looks like now to view it, it's saying you have to go to person and MCIS. So you log into MCIS the same way that you used to. You click on person, then you click on POC request. And then once you click on POC request, you should be able to view the POC. You have to click on the current one, the most recent one for the person. So whichever recent one in this demonstration she gave, it would be 5/25/20. And then you click view plan of care and you'll be able to see the authorization for the person in MCIS. It's no longer under the profile tab where you click waiver. It's under the person tab, plan of care, POC request.
Hello, everybody. This is Anika. I'm from the waiver unit. I apologize. I was trying to unmute. Hi, Shasta. I just wanted to come in and add to what you're saying. Yeah, this function, well, usually in the past, we would approve the service and submit the prior authorization form to the providers, but now we are no longer submitting that form. So now you have access to actually go in MCIS and create your own PDF form and print it out and retrieve it and do everything yourself. So what Pam did was send the directions so you can be able to go in MCIS and retrieve the PDF yourself. So what Shasta was just explaining was how to go to the tab with person. You go to person, you go down to POC requests. You will select the first, which is the most current year, and you would click POC review. And from there, you would select prior auth report. So when you select prior auth report, you're able to then generate your PDF form and you could print it out yourself. And that's just the same thing as what we would submit to you all when we would approve the service. So now you have access to print off your own service approval. So it's no new section that's in MCIS. It's always been there. It's just you have access now to retrieve your service authorization approval.
Thank you very much. So the next question that I see is it possible that weekly, biweekly, or monthly testing for staff could be mandated? So to date, and perhaps DC Health can speak to this, to date, there is no requirement for routine testing for staff. Some of our providers are doing routine testing and some are not. And I do think we are actually making sure that we have the data on that so that we can see whether, the impact of routine testing on our outcomes. Because whether that routine testing would be effective in preventing COVID infections is a good question. But to date, I know that it is not required by DC Health. And I also know that some of our providers with some of our better outcomes are not doing routine testing. So I want to go back and emphasize what I had talked about before, which is there are a number of factors that are essential in reducing the risk of transmission of coronavirus. And we know these things to be true, which is routine, consistent, regular, I don't know how many adjectives to use of masking in our congregate settings, intermediate care facilities, and res habs. Face shields need to be used. Maintaining physical distance and regular hand washing. And so if DC Health can speak to, the decision regarding routine testing, I also, as we talk about it, want to sort of emphasize for people as well, we have a workforce of about 4,500 DSPs. Just within our ICF community, we're talking about more than 50 placements and more than 1,000 people. So as you start to think about the logistics of being able to test all of those people in a routine way and the number of tests you'd be doing and how soon you'd be getting the results back. But anyway, if someone from DC Health can speak to that, I would appreciate it.
Thank you, Director Reese. I think you answered it pretty well, actually. I think it's also important to note that testing is not a substitute for those everyday protection measures. And so I think it's really easy, and we're seeing this, people getting, COVID fatigue, where they're just tired of all these different interventions, but and it's really easy to get that false sense of security that, because I'm tested every week, I don't have to wear a mask, or I don't have to wear eye protection and so on. But it's not a substitute. And so at this time, you're correct, there's no mandate from DC Health for that type of testing. Certainly, if the agencies choose that they want to do that on their own, that they are more than welcome to do that. But I think it's important that, what I said, that it's not a substitute for everyday prevention measures, just as you said also. Thank you.
Thank you. And actually, you can stick around because this next one is for someone
Sure.
at DC Health as well, which is, does DC Health anticipate changing the quarantine guidance based on the new CDC guidance, which just came out, potentially adjusting the quarantine time? It says from 14 days down to 7 to 10 days. And I do know actually that the mayor's guidance regarding out-of-town travel has already been adjusted, but I don't know if there's any thought about
Sure.
changing. I'm trying to think of where the actual quarantine guidance is in the DC Health guidance, but is that something that DC Health is looking at?
Sure. So actually, I did anticipate this question coming through, and we are still in the process of kind of digesting this new guidance from the CDC and understanding the reasons for why they're changing their recommendations and looking at their source materials, because as we see, a little bit of a spike in positive cases in the community, I think some of us at DC Health and just in general feel a certain kind of way about now reducing the quarantine time. And so we're discussing internally how best to address these new recommendations, and there will be updated guidance coming out. I hope by the end of next week, but it may be the week after. It's just going to kind of depend. We just need to determine what's best for our jurisdiction given the new guidance.
Thank you. And someone asked if we could put the case numbers in the chat box, which I did. They were both in PowerPoint and in my handwritten notes, so neither of those lended themselves to cut and paste. So I've typed them in, I hope in a format that you can decipher. There was a request for updates on the number of staff, which I did provide. So I'm hoping that came before I was speaking about the number of staff, but it's a short list. So to date, it's been 443 provider staff. And to date, 8 deaths have been reported. And 34 of the 443 staff worked at more than one agency. Can you provide insight how day services can be provided virtually to people supported that live in a residential setting and are also receiving companion services? We cannot bill for both at the same time. Service coordination shared that we can provide employment options, supported employment, and job readiness, actually, which it doesn't say here, through RSA. Yes, that is possible. RSA did provide guidance to all of our providers, I thought, on exactly what's needed in order to provide job readiness services that could be funded through RSA, so that for people for whom you want to provide virtual employment readiness or virtual job readiness, and the person has to be receiving in-person Medicaid funded services, which you can't do two Medicaid funded services at the same time. RSA can authorize those services. We opened it up so that all of our have done so. If you have not, that is easy enough. I believe the solicitation stays open. It gets closed down so that they can add the people, but anyone who is qualified as an employment readiness provider just needs to submit that they meet the qualifications and wish to provide job readiness. And then I don't know if Daryl is on the line. He can walk through what needs to be submitted to RSA, but essentially there does need to be a curriculum of what is provided. There are a number of hours of service that can be provided, and those can be renewed based on a person's progress in job readiness. Job readiness, like employment readiness, is about preparing to go to work. One of the changes in our waiver in 2017 was a limitation on how long we can provide employment readiness. And so, I always like to say to people, the best employment readiness service is a job, because where most people learn the skills for working is at work. And employment readiness is not intended to be something that goes on for years and years and years, but is something that is teaching people specific skills so that they can begin working. I see a question, but it feels like it's responding to someone else's, so I don't. So we are no longer getting notification when they are approved, which means we have to, this must be back to the POC question, I'm assuming. We have to keep going to verify that it has been approved. Is this going to be addressed? So I am assuming that all of the POC questions I read were answered. So notifications are provided via direct emails now.
Director Reese, there are a few people who are privately emailing me saying they do not see the numbers that you've posted. So if we could just kind of repost those for everyone.
Okay. Oh, because I did what I told you not to do. So go, which is I didn't post it to everyone. I just told the panelists. Now it's been posted for everyone. Thank you. Do ICFs fall, I assume, under the umbrella of long-term care, which will be the first group of people to receive vaccines according to current CDC guidance? What about residential habilitation and supported living? So just so that people are aware, you can go to coronavirus.dc.gov /vaccine, and you will get the current priorities, the CDC guidance, and the federal guidance is guidance for the states, and then the states implement that in the manner that works for that state. ICF, people who live in intermediate care facility and residential habilitation are in Group 1A. People in supported living, most of the other people that we support would be in Group 1B. So, so yes, the highest priority are the people who are the most vulnerable. The issue of who actually constitutes a healthcare provider, because healthcare providers are in Group 1A, but that's going to be a more difficult question, I think. And so when I tried to read the guidance earlier today, opening that website crashed my computer. So I'm not sure exactly how specific the details are, but there is a panel that advises Dr. Nesbitt on priority for providing the vaccine. What I read this morning, Mayor Bowser is trying to work with the federal government to have more vaccine allocated to the district. It looked like in the first round, we will have about 6,000 doses. So, you know, when you consider the number of healthcare workers, you know, as I said before, our DSP workforce is 4,500 people. Our DSP workforce in ICFs alone is over 1,000 people. And then when you consider, you know, healthcare workers in hospitals in the district. So, you know, the work of balancing all of those priorities is a tremendous challenge. But what I do know, because I did hear this morning from Dr. Nesbitt and have had this confirmed before, Dr. Nesbitt recognizes our population as one of the highest priorities. And in fact, in the guidance that's been issued to date, people living in ICFs and res habs are considered among the highest priorities. So I do see a comment responding to someone that you will only see the people you serve. MCIS is set up to view the people individually. So you would have to view each person individually. This is in response to a question, I assume, regarding the POC issue. So I don't see any additional questions in the chat box. I will do what I did earlier today, which in my, in an earlier meeting today, I had said to people, I'll just give you this many minutes and then we'll end, because in my experience, kind of like in my experience as a social worker, it's those important things that people ask you as they walk out the door that are often the most important questions to have to deal with. So I always like to let people know when we're about to end so that we can get those in and talk about them. So I thought I had answered this. Is the count for vaccines inclusive of both persons supported and staff who work directly with those people? I know very clearly it is people supported. If, as I said, if you start talking about staff in addition, when you consider that DC initially has 6,000 and ICFs alone, and DC Health is considering both ICFs and ResHabs in their calculation, and I don't know how many staff we have at ResHabs, but ICFs alone, we're talking about more than 1,000 staff. I think that being in category 1A for the staff will be challenging. I would invite you, however, to look at coronavirus.dc.gov/vaccine. They ran out of tabs, so you information about the priority groups and who falls in them. While the staff who work there may not be category 1A, they would be category 1B.
Director Reese, can you just repeat that, please? There's a part of your conversation that cut out.
Okay, so the question related to whether staff supporting the people at ICFs and ResHabs would be counted in that total. I would invite people to look at coronavirus.dc.gov/vaccine. As I had said, well over 1,000 staff. When you consider that the initial number of vaccines currently that the district is slated to receive, now Mayor Bowser is working to get that increased, but the number as it stands right now is about 6,000. I expect that the provider staff would be in group 1B. I do know for certain that the people we support in ICFs and ResHabs are in 1A. There was a question, when vaccines are released, will DSPs be required to get them? And perhaps I can let DC Health speak to this, but I did have this question earlier today, so I'm going to give the response I gave, and maybe DC Health can tell me if I was incorrect on this. To date, I have heard nothing indicating that there will be a requirement to get the vaccine. One of the things I have heard a fair amount about is some reluctance by people to get a vaccine. And I don't think that the way to deal with those concerns that people may have about a vaccine is by mandating it, but by providing education about the positive impacts and the side effects that one can expect from a vaccine, so that you convince people of the benefits of getting it. I do not believe that in any setting at this point it is being mandated, but DC Health may have other information about that.
Hi, good afternoon, everyone. We have no intention of making it a mandatory vaccine. One, I agree with Director Reese's comments about how mandating things is usually not the best way to get buy-in. Also, even if mandating a vaccine was something we were considering, it probably wouldn't be the most ethical thing to do, to mandate something that has been approved on an emergency basis when there's, significantly less safety data available than with other approved vaccines or medications. So DC Health has no intention of making an emergency use product mandated.
Thank you. Can you talk about travel and essential workers, specifically DSPs, and the mayor's order dated November 6th? It would help if you could tell me specifically. I can look up mayor's orders and get there eventually, but could you type in which, are you referring to the mayor's order regarding out-of-town travel? Because what I can tell you is that that the mayor's order requires that if you travel to particular states, which is now almost every state in the union, I will say, except Virginia or Maryland, but there is a list of those states on the mayor's website. So travel by district residents. If you go to one of those states, you are required to quarantine upon return. There was some update in that requirement in that I think it was 4 to 7 days after your return, you could get a test and then could return to work. My understanding, and now I'm going to try and look up the order. So my understanding of the order was that it did not apply to people who traveled out of state on essential work. There was not an exception, if I'm not mistaken, for people who travel out of state and do essential work. And perhaps DC Health knows the answer to that one. I'm pretty sure if we have a DSP who has traveled to one of those parts of the country, they need to follow the same guidance that the rest of us follow, and that they should not be going back to work until the time has passed, they've gotten a test and confirmed it negative. But like I say, I'd need to look at the order. My reading of it when it came out and my recollection this moment is the exception is for doing essential work out of state. So did anyone have a different interpretation of that requirement from what I just said? Yeah, so it's very important, and this has been an issue. One of the things that I did notice and talk to different people about is that as you are doing screening for visitors or for your staff, that we need to make sure that we continue to update our screening tools to take into account current requirements, so that the screening tool should no longer ask, have you traveled out of the country in the last 2 weeks? Only. It should ask whether you've traveled to any of the states that have been identified by the mayor as a high-risk state in the last 2 weeks, and therefore would have needed to quarantine, because you should not be out of your home, much less going into, you know, a home where people who potentially are really at high risk for serious outcome from COVID are living. Can DC Health expand on a recommendation of mid-shift temperature checks? So I don't believe there is a DC Health requirement for mid-shift temperature checks. I do know, because I heard people talking about this morning, that in the director of nursing meeting, there was a discussion about whether that would be a good measure for providers to adopt on their own, to just ensure that staff in the middle of their shift or every 4 hours over their shift be checking their own temperature, just to ensure that they are, you know, that they're as healthy as when they got there. But that is not a DC Health requirement, and it's not a district requirement. So is there a DC Health recommendation on low temperature readings for staff who are coming in from the cold, since you have to check their temperature before they enter the house? I would say you need to check their temperature in a place and manner, and this is just me, and I'll allow DC Health to answer, in a place and manner that you can get an accurate temperature reading. Is that a fair statement?
That's a fair statement, Director Reese. I think that's one of those operational things, and where, things in a perfect world on paper, it's always normal temperature outside. It's never cold. It's easy to take someone's temperature. But, you're at the limitation of whatever device you're using. And so if the device you're using to take the temperature is going to be affected by coming in over the cold, then you need to take measures to ensure that you're getting an accurate reading. And then also back on the travel guidance, I just wanted to remind everyone that the travel guidance was updated on November 27th. From DC Health, so please go back and review that. I think it answers most of those exceptions pretty clearly. And I actually wasn't sure the exact question that was being asked. I think it was related to the mayor's order specifically, but we did release guidance on the 27th that I would encourage everyone to review, that can be found on coronavirus.dc.gov.
And that would be under the health guidance? And in which section?
It's under both sections actually now, so you can go under health guidance, and I think it's towards the bottom. It says travel guidance, and then in parentheses, I think it says November 27th, if I recall.
Thank you. So I see a really good question. Can you discuss the consent process for people we support receiving the vaccine? No, and I don't know if DC Health can answer that. What's the consent going to look like? And I expect there has to be informed consent, which means that it would be the same informed consent as exists for any other medical procedure that a person gets. Whoever has the authority to provide informed consent would need to provide the informed consent for this particular procedure.
I would say that's correct, Director Reese. I'm not really sure the question. The consent process is the same now as it's always been for anything like this or similar to this. It doesn't change just because it's a new vaccine.
So QAPMA sent an email to providers November 25th saying DSPs need to follow the mayor's order regarding travel precautions. That's correct, they did, because I asked them to. Because I asked that they remind people that there is guidance about travel, and what Mr. Vannucci is telling us is that on the 27th, it was updated. The email that went out was the 25th. Just reminding people that if you were traveling for Thanksgiving, which was not recommended, but if you were, and you traveled to one of those hot spots, that you should not, that you should be quarantining upon return. The link to the guidance is in the chat box, so people should take a look at that and remind themselves of what it says, especially because we're about to come upon another holiday season where there may be questions about travel. So can we develop? We have not developed. So there's a question, has health and wellness developed? No. Or can they develop tools to help us with education for people regarding consent for the vaccine? And I think that's a really good thing for us to work on along with DC Health, because I know that DC Health is doing a lot of work right now on education for the general public about the vaccine. And so we need to make sure that we're providing education also for people who may be consenting on their own so that they understand this well. I think that's a really good idea. So we will, as I say, we'll talk to DC Health about the kind of public education they are doing, and also look at, what kind of education we can provide for people so that when they provide informed consent for the vaccine, it is truly informed. Okay, so now we're actually at 104. So I hope that everyone has a nice weekend, stays safe. And, you know, as I said in the beginning, I understand, you know, how long this has gone on. Please remember, even though we have on the horizon a vaccine, there's 350 million of us in this country. It's going to be a long time before we are at a place where we can begin to reduce our vigilance about about always using a mask whenever we're outside around other people, you know, whenever we leave home, about maintaining physical distance, regularly washing our hands. This should see our flu really drop this year. Because we should be taking really good preventive health care, really good care of ourselves. So I'm hoping everyone is taking good care of themselves. It is so essential because to the extent we come in contact with anyone who is at higher risk for serious outcomes, this virus does still have really serious outcomes for some people. So please take care of yourselves and think about the people that you work with or come in contact with as you do everything you need to do to take care of your own health. So thanks a lot, and I will talk with people next week.